questions. Dr. Manav, I think we spoke on ACLF transplant and we spoke about organ failures. But what about sarcopenia? They are very frail. There's no assessment for that. What about immune dysfunction? You might have a culture positive, you have treated that. But if a person has recurrent infections, his immune system is completely trashed. And he might have a successful transplant, but might land up with a very bad MDROs in the post-transplant period. So what about these two factors?
So this is the catch-22 actually. So sarcopenia can never be an absolute contraindication to transplant. And in a child C cirrhotic, you cannot even improve the sarcopenia without changing the liver. So it's a catch-22. You understand that they have a higher mortality after transplant, primarily because of infections. But if you don't transplant them, you are anyway losing. So, but that higher mortality is limited to, I would say, 15-20%. In 80% of sarcopenic patients, you will get good survival. So sarcopenia for us is not a contraindication. Obviously, we try to build the patient up, but practically speaking, you cannot improve sarcopenia without a good liver. Right, that answers one. Secondly, immune dysfunction and MDR infections. So when I said infections, I also was very specific about saying that you see the sensitive antibiotic, give them for 48 hours, and then do the transplant. In an MDR, you don't have sensitive antibiotics. So you have to document reversal of infection. A repeated culture has to be negative. Because many times you have a discrepancy between in vivo and in vitro sensitivity. So if we have a MDR in a CLD patient, we'll go all out with whatever antibiotics we can give, we'll repeat a culture. If the repeat culture is positive, we'll not transplant. We are very clear about that. On the other hand, if the repeat culture after 48, 72 hours is negative, we'll go ahead. If the ACLF3 gives that much time.
Why don't you sit down? Yeah.
This question is Dr. Soin, sir. Thanks for the lovely talk. I work in the government hospitals. We don't have patients who can afford atezolizumab. But we occasionally see these patients with the HCC, which is like, say, 6 to 7 centimeters, with the tumor PVT. So, sir, while the patients are undergoing SBRT for the tumor PVT, and we are documenting response, like it takes around 2 months, as you said in your protocol. So, in that time, is there any role of TACE or anything to bridge so that the tumor doesn't grow beyond the...
So, in general, TACE is not a good idea for patients with thrombus in the portal vein, because then you're going to basically block the entire blood supply of that side of the liver. So TACE is generally to be stayed away from. But occasionally it can be used where the tumor thrombus is segmental, if it's not actually in the right or the left portal vein. So, but I think the circumstances that allow you that are very small in number. What you can do is that if you're worried about progression, you can put them on TKIs in the intervening period of that 6 to 8 weeks.
Thank you, sir.
Hi, Manav, excellent presentation. Just one comment, or maybe I would need your opinion on that is, we had analyzed our own ACLF data who underwent transplant, and one thing which came out, patients who didn't do well, were those with marginal donors. So I think even those who were 45, 50 years of, which usually would be considered as an appropriate donor for an otherwise stable patient. But what we found is that if the patients are having standard relative contraindications, but if the donor is not very good, or a so-called marginal donor, that is, those patients don't do well. So your thoughts, and maybe Dr.
That's a very, very valid point. ACLF patient after transplant has a very high metabolic demand. So everything has to be perfect. Marginal donors we don't accept for ACLF3. I'll go a step further. If one of the hepatic veins gets screwed up after transplant, immediately after transplant, even that gives you a major issue. So you have to have a perfect surgery and a perfect graft for when you're transplanting ACLF3. You want to comment?
Okay.
Surgeons do a perfect job, that's what he's saying. So,
for Dr. Soin, sir, I think, can I ask for... So what is the waiting period? So after the thrombosis has disappeared on imaging, how much time do you wait for a living donor transplant? What is the waiting period you follow, sir?
So it would be at least 2 months.
Okay.
Yeah.
Thank you.
Yeah, Amit, for that question we put to Manav, I think that the publication which Shweta did, three factors. One was higher donor age.
So
Yeah,
I
yeah, exactly.
specifically did not talk about the donor
Yeah,
factor
but-
because that's
but
a
I think-
separate presentation altogether. Yeah.
I think it's 50 plus. I think, but the three factors: higher donor age, PF ratio. Yeah, yeah. So I think that makes sense that marginal donors would not be the right thing to do in such patients.
Yeah, Manav sir, excellent presentation. So my question to you is, in this ACLF3, where do you position Plex with regards to optimizing organ failure and maybe making the outcomes better? Do you see any role of Plex in a selected ACLF3 population?
See, when you don't have a donor or it is delayed due to some reason, we'd offer Plex to most of these patients. But I'll tell you what, in our own experience, Plex does not work well for ACLF. It works well for ALF patients. I would have doubts using Plex in a patient who's otherwise stable. So a sinking ACLF3 donor waiting, I might try it out of desperation, but I'm not happy with Plex in ACLF. Is Rakhi here? Rakhi would be able to comment better. She has more experience on this, but my own experience with Plex in ACLF is not very good. Vinender is here. Vinender, why don't you?
So I was just coming to it. So yeah, I will agree. Plex in a stable patient can be a double whammy. Actually, you are actually getting one more hit on top of ACLF, and I'll actually say on ALF as well. In a stable ALF, you should not be doing Plex. That's what I will think, because it's Plex actually clears both the things. So it will actually remove both the good and the bad as well. So where the patient will go, you don't know. So I just wanted to ask you, what should be your way of making a decision in an ACLF3 who is on Plex and on CRRT? Because this is what is happening now, and this is common actually. This has become very common that you get an ACLF3 multi-organ failure, they will be getting Plex and they will be getting CRRT. This has become, I think this has sort of become norm now to put them on those things. And how you decide whether to take them for transplant or not really.
So I discussed the literature with all the fallacies. I'll tell you what we do. If the patient is on renal replacement therapy for renal causes, we don't do the transplant in ACL.
So the CRRT is done for hyperammonia in this situation, not for renal causes. Most of the time what happens is this is hyperammonemia, and that's why CRRT is being done. The indication is, most of the time it is not because of renal
in a
failure.
ACLF, we don't do CRRT for hyperammonia in our unit. If somebody is doing CRRT for hyperammonia in ACLF, I would not hesitate taking that patient up for a transplant. But in our unit, we do not do CRRT in ACLF for hyperammonia.
So
it's only done for ALF. In all ALFs we do, but ACLF we don't.
So now we'll just keep the scenario right. We've got a patient on ventilator, some ionotropes, urine, oliguric, on CRRT, had couple of sessions of Plex as well, and you have to decide on this patient whether you want to, there is a donor ready, whether you want to take this patient for transplant or you want to wait further, and how long you're going to wait for that optimization.
So-
It's just for the discussion. I know
Yeah.
what
So
the decision will be.
what's your hesitation in taking up a transplant?
Yeah. So that's what. So I think these are scenarios where you should be actually taking them rather than hesitating, because that's what happens. People hesitate, and then actually, the relatives actually at that time what happens is, because there is some optimization has happened, patient is stabilized, and they think that patient might be improving on a medical treatment, but that is not going to happen. Patient, another 3-4 days, patient is going to go down the line, and they may become untransplantable. So that's the window actually which need to be catched up.
I mean, I agree. That's what I would do. And I also agree with Manav when you said that patients with circulatory compromise, patients with pneumonia, like a clear lung issue, and those with signs of clear infection, those are the ones to stay away from. The others, you should just go ahead, of course.
One question to Soin sir. Excellent presentation, sir. Regarding this downstaging, in your experience, how many patients decompensate liver-wise when they are on this downstaging and don't reach transplant? Any data on that in the group of PVTT who undergo this downstaging with tear and SBRT. Till we reach transplant, any significant decompensation you have seen in the patient?
So the number of patients that decompensate in our system are not more than 10% because we take patients who are childs A and B and whose bilirubin is quite low, they don't have ascites, their non-tumor volume of the liver is substantial. So we do have occasional patients going into decompensation, but not a lot.
Okay, thank you.
I have one question for Dr. Sain. So, see, you talk about TARE and SBRT in a select subgroup of patients. They are generally A5 at max A6, right? Small tumor volume, large liver. And you are comparing them with TASTE data or TARE data or lenvatinib data of all comers. So have you ever tried that a patient who underwent a TARE plus SBRT, all his FDG avidity disappeared and we did not transplant? To me, that patient may go on to live 5 years on its own, even without a transplant.
So what you say is theoretically possible, but practically you can't do that study. That's the problem.
No, one of that won't happen actually. That tumors will come back. This doesn't happen, and you should not think those need transplant. So, Dr. Sain, actually, one of the things, I don't know if I got it wrong. During your presentation, you said all size, all numbers, irrespective, you will transplant. And then the ones who have PVTT will go down the line, your protocol, which is very good. So, when you say all size, all number, do you take tumor biology in consideration before transplantation, or you will go ahead and transplant them irrespective? So are those patients not going through downstaging protocol?
So we didn't talk about non-PVTT protocols.
Well, you did said during that algorithm that if they are transplantable, all size, all number will go towards surgery.
Yeah, that's right. So the thing is that we have, again, published data, which Prashant just talked about in his I think you did mention that study, right? Where we consider 3 things, beyond UCSF, FDG, and alpha-fetoprotein. And if they have all 3 risk factors, they will be downstaged because their recurrence rates are more than 25%. That's what we showed in our study. And we do downstage them. We also downstage patients who have excessively high tumor markers. I would say like beyond 1,000 of PIVCA and or AFP. So we will tend to downstage them if possible, but not all of them.
Not all. Okay. Yeah. So, just
when I say possible, you may have somebody.
So I know we keep talking about advanced HCC, and so I'll just give you one small scenario: 3 centimeter HCC, alpha-fetoprotein of 1200. Are you going to straight away transplant, or are you going to do some downstaging therapy before transplant? LDLT, donor ready.
But I think I've done.
Those are more important questions.
So this is as rare as the scenario that he painted, actually.
Thank you for the excellent presentation.
Yeah, so that's my answer.
Dr. Soin, Dr. Subhash, and Manav. We'll close the discussion.